Welcome to this lecture. My name is Absetz and I'm an adjunct professor of health promotion and a research director specialized in behavioral and implementation sciences. Today I'm based in Helsinki, which is the capital of Finland. My talk today will be on crossing the implementation gap in public health. I'm pretty sure you all recognize this picture. In the beginning of 2020, implementation gap in public health for most of us here in Finland, as well as for people in other high-income countries, meant suboptimal implementation of evidence-based interventions for prevention and management of non-communicable diseases, or NCDs. Now, COVID-19 has changed all of this. For that condition, our primary evidence-based intervention, or EB, is social distancing to stop spreading the virus. And we all have seen what a struggle the implementation has been. But for many other communicable diseases, we've been very successful across the world. Smallpox and polio are already history, measles might be soon. In Finland, implementation of national vaccination program has been extremely successful, especially among children, with immunization coverage well over 90% for all other diseases and 50% also for annual influenza vaccines. However, the situation for NCDs is still much worse. Looking at the major causes of death worldwide, we can see that non-communicable diseases are the biggest health threat and probably will still continue to be so also after the current COVID-19 pandemic. Let's look more closely at diabetes. Of all the cases, vast majority are type 2. We already have over 400 million cases worldwide, and that figure is estimated to increase by almost 50% in the next 25 years. However, this increase affects our populations disproportionately. In high-income countries, it affects mostly socioeconomically disadvantaged populations. The biggest increase, however, will be seen in low and middle-income countries. The largest relative increase of more than 150% is projected for sub-Saharan Africa, while the largest absolute increase of 70 million cases is projected for Southeast Asia. The dramatic increase in diabetes prevalence in low and middle income countries is a cause of concern, especially as these countries are poorly equipped to manage the disease. People with the disease too often remain undiagnosed until severe complications of death, and while almost 90% of diabetes deaths occur in these countries, only 35% of diabetes-related health expenditure is spent by them. So there are important gaps both in detection of people with diabetes and its risk, as well as provision of adequate care. Here are some figures from India highlighting the gravity of the situation. Among those with a diagnosis, 80% have uncontrolled blood glucose level. Just look at the mean HbA1c values among patients living with diabetes in major Indian cities. Poorly controlled disease leads to blindness and amputations and severe life-threatening complications such as end-stage renal disease and heart disease. And just to quickly highlight the risk that diabetes poses for vascular outcomes, also here in Europe. So although many of my examples today come from low and middle income countries, this is not a problem without relevance to high income countries as well. This is especially disturbing because we've had evidence for 20 years already that when it comes to type 2 diabetes, which as I said accounts for the majority of all diabetes cases, this condition could be prevented with healthy lifestyle. The same everyday healthy behaviors that will also help to control it and to avoid complications and to avoid premature death. Here is some of the evidence for prevention. As a Finn, I want to highlight findings from some of my Finnish colleagues. Professors Jaakko Tuomilehto and Jana Lindström published this landmark study, the Finnish Diabetes Prevention Study, showing the efficacy of lifestyle change. There was a clear relationship between the number of lifestyle goals the participants achieved and the disease outcome. Among those who reached all the 5 lifestyle goals, no one developed type 2 diabetes during the follow-up. All in all, the intervention group had a significantly higher probability of remaining disease-free during the 8-year follow-up. Furthermore, 2 years ago, a research group from the UK published findings showing that also remission of type 2 diabetes is possible by lifestyle change and weight loss instead of medication. Same as with type 2 diabetes prevention and control, success in reaching lifestyle goals predicts survival also among patients with heart disease. So it is clear that the number of lifestyle goals achieved clearly makes a difference. Similarly, the dose of counseling that is being offered really matters. This table is from a systematic review for the US Preventive Services Task Force by Lin and colleagues. The findings show that although also lower doses of behavioral counseling are effective in changing behavior, there is a dose-response relationship and higher doses may be needed for showing risk factor reduction. My colleague, Professor Janne Martikainen from the University of Eastern Finland has calculated potential savings from lifestyle intervention to prevent type 2 diabetes. These calculations were based on costs from our joint project, the Stop Diabetes study. Janne used a rather modest but realistic expectation for weight loss, considering that the Finnish people in general tend to gain at least a half a kilo of weight per year. Even a modest weight loss or weight maintenance can make a difference. Here, the intervention would start saving costs after 5 years. Another trial that I've been involved with tested telehealth coaching among patients with poorly controlled type 2 diabetes and cardiovascular disease, the TERVA trial. We've just published the results on health and social care costs from an 8-year follow-up. But before I show those results, let's look briefly at what the TERVA intervention was about. Participants were patients who did not meet treatment targets at their healthcare. They were identified from electronic patient records and they received a 12-month program of strength-based behavioral coaching. The program was delivered by health coaches who were specially trained to do the work, and they delivered the intervention as monthly telephone calls. The coaching was based on 8 key recommendations. And the calls followed simple steps of assessment of needs, recommendation, and monitoring and evaluation. The coaching unit was set up by the regional public healthcare organization and operated from a call center which was placed outside of healthcare centers. Findings at 1-year follow-up were very disappointing, with small changes in the primary outcomes of hypertension, blood lipids, and glucose only. However, when looking at the health and social care costs in the intervention and control groups during an 8-year follow-up, we were able to see that after 2 years, the intervention started to show impact. Eventually, the saving per participant who had received the intervention as per protocol reached an average €6,000. The return on investment for Terva was 14, meaning that the program helped the regional healthcare save 14 euros for each 1 euro they had spent on the intervention. Based on the research, the potential return on investment from social and healthcare costs would have saved the region almost 50 million euros if the program had been retained and scaled up in the region. However, instead of scaling up the program after the trial, the program had been terminated. The call center had been closed and the coaches had moved on with their lives. Maybe the policymakers were too impatient, but my guess is that if we had invested more on conducting rigorous implementation research, our key stakeholders would have experienced also other kinds of benefits from the program. Healthcare professionals might have been more eager to advocate the program, and policymakers might have had more patience to wait for the outcomes. So even effective and cost-effective programs are not being scaled up. And there is an implementation gap in prevention and control of NCTs, which we are far too slow to cross, and that costs us quality of life, lives, and money. In fact, it has been estimated that the average gap from evidence to wider implementation is almost 20 years, and even then implementation remains suboptimal. This estimation has been pretty accurate in diabetes prevention. The Finnish diabetes prevention study that we already looked at was one of the first efficacy trials to show the effect of lifestyle modification, and it was published in 2001. We conducted one of the first studies testing effectiveness in real world and published its first findings in 2007. We also culturally translated the program into India and tested it there with published results in 2018. Meanwhile, in Finland, a large-scale implementation of diabetes prevention is still a challenge, which we've been trying to address in the Stop Diabetes study that I also already mentioned. So let's look at how we can use implementation research to bridge the gap and improve NCD prevention and control. This figure depicts the chain of different types of studies that are needed when moving from evidence all the way until to public health impact. First, you need basic research and experimental research with animals to investigate the mechanisms of health and illness. And then these have been tested for clinical effectiveness in clinical trials and case studies. Efficacy has been established in trials under controlled conditions, and then effectiveness in real world has also been tested. Finally, implementation and scale-up studies test the public health impact with different types of delivery methods. Implementation research covers the last two with pragmatic and hybrid trial designs. Let's take a look at some key characteristics of traditional versus pragmatic trials. I'll talk more about hybrid designs in a moment, but for now, just keep in mind that the hybrid designs share characteristics of the pragmatic trials. So the pragmatic trials really are real-world studies with wide range of patients, providers, and settings, and few exclusion criteria. Being real-world sets a lot of requirements that often lead to compromises with study rigor in the strictest sense, but increase external validity, feasibility, and contextual adaptability. Stakeholder involvement is a necessity at all stages of the study. Let's look briefly at the three different types of hybrid designs. The main difference between these designs is what kinds of outcomes they are looking at. Hybrid type 1 aims at testing effectiveness of an evidence-based intervention while also gathering data on implementation. Hybrid type 2 has two simultaneous aims: to test effectiveness and implementation. And hybrid type 3 is mainly interested in testing implementation strategies. There is already proof of effectiveness, so effectiveness is followed, for example, from existing data sources rather than tested in controlled experimental design. Most of the implementation studies that I've been involved with are type 1 or type 2. So, for example, in the GOAL program that I just mentioned, as one of the first real-world implementation studies of diabetes prevention, we tested the effectiveness of a theory-based model for lifestyle change and collected data on implementation using the RE-AIM framework that I'll talk more about in a moment. In the KDPP study in India, the program was culturally translated and also the delivery method was different, so we tested both effectiveness and implementation. In the Stop Diabetes, our intervention consisted of lifestyle coaching delivered by health professionals and a novel digital solution, again testing for effectiveness and implementation. One important question in implementation research is this: on which level is your intervention operating, and are you addressing all the levels you should in order to have successful implementation that will also lead to maintenance of your program? I point at myself mostly when I say that we focus too much on the patient or person level and put far too little effort into designing a proper intervention to target professionals, organizations, systems, and policymakers. On those higher levels, rather than applying our theories on behavioral and organizational change together with proper intervention methodology, we still often think that if the stakeholders just had the knowledge of our EBs, they would be willing and able to adopt the EBs into practice. But we know that knowledge is not sufficient to change patient behavior. So why do we think it would be sufficient to change our stakeholders' behavior? So I said we should use our theories on all levels. Why are theories so useful? First of all, theories help us to understand, to interpret, to predict, and to make an impact. They can inform us on which level to intervene. Also, they point at determinants to target with our interventions, and they help to select appropriate intervention strategies. Finally, theories suggest what to measure and evaluate to find why our intervention worked or failed. We all have theories, but often they are implicit. We don't recognize them. For example, I've found that many health professionals have an implicit theory of or an expert script that they utilize also when guiding patients in lifestyle change. However, I've also found that the model that people actually follow looks very different. This model also fails when it meets the reality of health systems in many parts of the world. Here, a figure mapping the patient process in Uganda based on our Smart 2D study needs assessment phase. You don't need to be able to read it to see that the process which is depicted with the red lines and arrows is not straightforward, quite the opposite. The patients bounce back and forth between all the different levels from household to community to formal health system with its different levels without any clear proactively planned pathway. The reason why I showed you these is this. Taken together, they show that if you want to implement a program that will help to prevent or manage type 2 diabetes with lifestyle change, you will need to consider all these 3 levels at least. So, you will need theories and intervention strategies to facilitate change in individuals, but you will also need theories and intervention strategies to facilitate change among professionals if they are the ones who are delivering your program. And you will need theories and intervention strategies that will facilitate a systems change if you want your programs to be maintained as part of routine practices in the systems. I find it useful to think of theories and frameworks by their functions. Here I separate 3 functions that I think are most important. First, to map the process that facilitates implementation. Second, to understand and leverage mechanisms of change. And third, to guide evaluation of effectiveness and implementation. Note that there are many theories that tap more than one function. What I really want to emphasize is that you will need more than one theory or framework. You will need to cover all 3 functions. And if you have more than one level to intervene, which I'm pretty sure you should have, you will probably need different theories to inform on the mechanisms of change on all those levels. One useful framework for mapping and guiding the process of your implementation research is intervention mapping. It will help you to plan the actual intervention as well as how to implement it, but also as an outcome it will provide you with an evaluation plan. So you start with a comprehensive needs assessment that will include a situational analysis of your context and the implementation gap. Then you define the changes you want to achieve and their determinants, and you write these into matrices. Thirdly, you select the best theoretical methods and the most feasible practical strategies for changing the determinants. In both these steps, you will need theories that address the mechanisms of change. Then you will plan how your program will look like. Once your program is ready, the next step is planning for adoption and implementation. There you will follow the same methodology all over again. But because here the changes that you want to achieve operate on a different level, also the theories for change need to operate on those levels. In real life, these steps are often overlapping. As a product of all these steps, you will get an evaluation plan for your program. As I said, the second function of theories is to help identify and address mechanisms of change. When looking for a theory, you want to make sure that it fulfills the criteria of a good theory. Your theory has to make sense. The concepts and their relationships need to be clear. You will need to be able to measure and test it. And it should be based on evidence. These criteria were outlined by Susan Mickey and colleagues in their ABC of behavior change. That's an extremely useful book when you want to learn about behavior change. Proceed model by Green and Kruder can help you to identify key behavioral and environmental factors that need to change in order to achieve the changes in health and quality of life outcomes. It can also help to think about their determinants. However, often we also need to take a closer look at what the personal and environmental determinants actually are. Here you either find a theory that fits well with your context, and again I refer to this guide. Or instead of one theory, you look for theoretical domains, constructs shared by many different theories that will help you to understand what are the key determinants in your case that need to be addressed. For example, maybe it's not a question of poor knowledge, but rather low confidence or self-efficacy in your target group that needs to be addressed. Or lack of environmental resources, or both of these. Some benefits of this framework are that it covers different potential means of influence, and also that it makes a distinction between different types of influence, and it links behavior change theories to behavior change techniques. Once you know your determinants, you can get guidance on techniques that will help you to change them. So, for example, for the environmental context and resources that we identified in the last slide, you can select techniques for changing the antecedents. And for beliefs about capabilities, you can find techniques that will help to change those as well. Finally, let's take a minute to look at the third function of theories, which is to guide comprehensive evaluation, covering both effectiveness outcomes as well as implementation outcomes. One of the most frequently used evaluation frameworks in this field is the RE-AIM, which I already mentioned earlier. Here you can see that it can also serve a double function, because of course you want to plan your study with your outcomes in mind. Here, while all the factors are important, I want to emphasize the importance of reach, especially in terms of your public health impact. In the RE-AIM, public health impact score is calculated as a product of all the factors. Hence, even with the small to medium effect intervention, the public health impact will be considerable if the reach is high. So maximizing your reach will bring much better return on investment than maximizing the impact of the intervention on only a few people. Hence, not only the penetration in your target population, but also willingness to participate are crucial. Furthermore, not only the clinical effectiveness, but also effectiveness in changing the determinants that are crucial for the change. And here are also some other considerations and reminders that I find important, such as measuring maintenance at all levels. In the beginning of my lecture, I talked about low and middle income countries and especially India, and I want to end this lecture by giving some practical examples from the Kerala Diabetes Prevention Program that I've been involved with in India together with Professor Tankapan and his colleagues from the Sri Chitra Institute in Trivandrum, Kerala, and Professor Brian Oldenburg and his team at the University of Melbourne in Australia. For adapting diabetes prevention from the GOAL program to India, we utilize the intervention mapping approach for planning purposes. The cultural adaptation has been described in this open access publication from a couple of years back. The proceed model helped us to understand the context and to identify behavior change objectives and their determinants. Following intervention mapping, we defined program objectives, theory-based methods and behavior change techniques, as well as practical intervention strategies. Don't worry if you can't read all the text on this slide or if you don't have time to read all of it. The table is also in the same publication. Dr. Zara Aziz, who was a PhD student of Brian Oldenburg and myself, conducted an implementation evaluation of the program as part of her PhD. For the evaluation, she combined the RE-AIM framework with another evaluation framework called the PIPE model to separate the provider and the participant levels, and she also added a third level to include the community that had proved important for the implementation of the study. Sarah's work has also really emphasized the importance of implementation for public health impact. Together with Professor Oldenburg, Professor Thankapan and other colleagues from India, we are working to scale up diabetes prevention in southern India. And for this project, we are utilizing a specific model for scaling up. However, currently this project is on the hold because of the COVID-19 pandemic. Although the COVID-19 has put many of our projects on hold at the moment, I want to leave you with some thoughts for post-COVID-19 time, because it will come sooner or later. First of all, I'm sure we will see chronic disease patients whose disease management has been neglected during this time, and they will need more help and support. We've also already learned about the impact that chronic conditions such as diabetes and heart diseases have on the severity of the virus. So I believe we will also see increased awareness among those at high NCD risks, as well as among healthcare professionals, about the importance of preventing and managing NCDs better to mitigate the impact of the virus. So while we certainly need the vaccine, I'm convinced that we also need improved implementation of NCD prevention and control now and in the future as well. Thank you for your attention, and wherever you are, stay safe.